access and quality in preventive care. He is a professor of the Department of Family and Community Medicine at the School of Medicine at UT San Antonio and a professor for the Department of Health Policy and Health Services Administration at the UT School of Public Health here in San Antonio. He serves as the executive director of the UT Health San Antonio Primary Care Center and oversees academic primary care practices, delivering team primary care across San Antonio. Dr. Cancino leads system-wide cancer prevention and screening efforts and directs multiple funded initiatives focused on colorectal and lung cancer screenings, including American Cancer Society supported projects and studies examining community healthcare worker navigation in patient populations. His work sits in the intersection of primary care and value-based care with a particular focus on improving cancer screening and outcomes in our community. We want to welcome Dr. Cancino. And Becky's my friend, so I really am excited to have her here. Dr. Rebecca Jones. She is an assistant professor of the department in the Department of Population Health Sciences, School of Medicine at UT San Antonio, and assistant director for the community outreach and engagement for the Mays Cancer Center. She has over 10 years of experience designing, implementing, and evaluating single and multi-site community engagement programs and clinical research focused on improving health outcomes across diverse populations. Dr. Jones currently directs the For Your Health program, delivering community health workers to enhance care coordination in primary care and work closely with health systems to strengthen community and clinical linkages. I want to welcome both of you and are very excited to have you both. Thank you.
Thank you, Belle.
Thanks for having us. All right, I think Dr. Jones, are you going to start our slides?
Yes.
All right, well, first of all, from the both of us, thank you all for having us today. We're really honored to be sharing our experiences and, whatever we can do to help to this very important group here in our community. Today, we're going to discuss strategies for engaging men in colorectal cancer screening, particularly those facing structural barriers related to poverty, access to care, and really keeping in mind that social context. Colorectal cancer remains one of the most preventable yet still deadly cancers in the United States. And screening can really prevent cancer through detection and removal of cancerous and precancerous lesions. And yet, many men, particularly those living in areas of persistent poverty, remain underscreened. And we believe that we can impact this number through some of the things that we're talking about today. We're going to focus on multidisciplinary teams, community health workers, and really paying attention to those non-medical drivers of health, which can help us close these gaps. Next slide. So colorectal cancer is the second leading cause of cancer death in the United States, and yet screening can really prevent these deaths. And so today's discussion will focus on four things. First, we're going to discuss the complementary roles of clinicians and community health workers in supporting colorectal cancer screening. Second, we will explore why health promotion efforts targeting men are particularly important. Men often engage differently with the healthcare system in the community. And so understanding this and how that works, I think, can really help us help our communities. Third, we will discuss non-medical drivers of health, factors like transportation, employment, housing stability, trust, and how these shape screening decisions and access to care. And then finally, we will share preliminary findings from our own work focused on increasing colorectal cancer screening in men in our community who live in areas of persistent poverty. Next slide. So historically, healthcare teams have operated within very hierarchical models. Physicians, nurses, nurse practitioners, physician assistants, social workers, direct care from the practices. And Often community health workers are brought in as an auxiliary resource rather than a core member of the care team. In this traditional structure, communication between team members may be quite limited, and community knowledge about patients' lived experiences is often not fully integrated into the clinical decision making. And a big reason for that is that communication may only be one way. The community health worker may not have an opportunity to update the whole care team about what is going on with the patients they are interacting with. And this information can be really necessary when addressing issues like cancer screening, where trust, navigation, and access barriers are central. This traditional model may no longer be sufficient. Next slide. And so a holistic, multidisciplinary approach recognizes that improving cancer screening requires more than silos of information built on clinical expertise. It requires collaboration among everyone on the care team, including community health workers, each of whom brings their unique skills and perspectives. These perspectives allow all to learn from one another, which can then allow for the goal, right? The best plan of care to be developed for each individual patient. Research shows that team-based models improve preventive care delivery, particularly in underserved populations, because they allow care teams to address medical needs alongside social barriers that often determine whether screening will actually occur. Next slide. And so I guess I'll say it again. In a true multidisciplinary model, community health workers play an important role on the team. Non-medical drivers of health, like socioeconomic factors, physical environment, health behaviors, transportation, can impact as much as 80% of a patient's overall health. And so community health workers can link patients with resources that influence factors and can also broaden access needs for patients, such as scheduling assistance and navigation through a healthcare system that can be quite complex. And so CHWs can also provide culturally tailored support to patients as well. That might mean communicating in patients' preferred language, addressing fears or misconceptions about screening, or helping patients navigate financial barriers. Evidence shows that community health workers improve preventive screening uptake, especially in underserved communities. Next slide. So a little bit about colorectal cancer screening. Current USPSTF guidelines recommend that colorectal cancer screening begin in adults age 45 for average risk adults through the age of 75. Specifically, it's a grade B recommendation for ages 45 to 49 and grade A recommendation for 50 to 75. For patients older than 75, ages 76 to 85, we usually recommend that screening decisions be individualized to the patient that's in front of you. Now, there are several modalities these days that patients can use for colorectal cancer screening, ranging from providing a stool sample to the gold standard, which is a colonoscopy. And depending on the modality that either the clinician partnering with the patient selects or what's required based on that patient's history, the screening interval can also change as well. So that's important to know. But again, a key point here is that the best screening test is usually the one that will get completed. And for many, like for example, those that need to provide a stool sample or getting a colonoscopy, which includes often taking medication required to prepare the gut for the procedure, taking a day off of work, finding transportation to and from the procedure, and even finding a gastroenterologist to do the procedure, this can be quite daunting. And so for the average patient, getting a colon cancer screening can be confusing. And when you combine that with some of the challenges other patient populations have to go through, it's no wonder that the colon cancer screening rate in the United States is not as high as we would like. Next slide. And so men are more likely to both develop and die from colorectal cancer compared to women. In the United States, colorectal cancer incidence is about 33% higher in men, and mortality rate is about 43% higher in men. And males typically have less colorectal cancer screening rates than do females. And so men's decisions about colorectal cancer screening are influenced by factors that often extend beyond traditional health education. Social support, health literacy, cultural expectations, perceptions of masculinity, all of these can influence screening behavior. For example, research has shown that men are more likely to delay preventive care and are less likely to engage in regular screening and appointments with their healthcare providers compared to women. These patterns contribute to delayed diagnoses as well as potentially worse outcomes in colon cancer. Next slide. Studies consistently show that men delay health care more often than women. Many men report avoiding medical visits due to discomfort, embarrassment, or concerns about being judged. And these factors are particularly relevant when discussing colorectal cancer screening for all of the issues I previously mentioned. Next slide. Another challenge is that many men underestimate their health risks. Despite believing they are generally healthy, many do not receive recommended preventive screenings or annual checkups. Additionally, many men don't know their own family history, which is especially important, particularly in the sense of colorectal cancer and its impact on family histories. Next slide. And so to better understand screening behavior, many public health interventions use the health belief model. This model proposes that a person's belief in a personal threat of an illness or disease, together with that person's belief in the effectiveness of the recommended behavior or action, will predict the likelihood the person will adopt that behavior. It's a little confusing, but maybe to put it a different way, people are more likely to take preventive action, like getting a colonoscopy, when they believe that they are at risk, when they believe the disease is serious, when they believe the intervention works, and when they believe they can overcome barriers to take action. That, for us, underlies the research we will talk about in the next few slides. Next slide, please. So here's a schematic of the health belief model. And so I'll walk you through it a little bit. I want to draw your attention first to kind of the top row: individual perception, modifying factors, and likelihood of action. When we think about individual perception, the thing we need to focus on is help patients understand their personal risk. That's what we call perceived susceptibility. Perceived susceptibility leads to modifying factors, which are perceived severity, perceived barriers, and then cues to action. These factors interact in our patient population, and you can see in the schematic how health behavior, like colon cancer screening, can be impacted by barriers and severity as perceived by the individual patient themselves. Physician recommendations, for example, can be viewed as either a cue to action or a factor that impacts self-efficacy. And then finally, perceived benefits, like understanding that colonoscopies can find and remove precancerous lesions and then can prevent death from cancer, also modify a patient's likelihood to action. At the end of the day, what this helps us think about is where we would like to intervene when we try to impact behaviors in our patient population. Now I'll turn it over to Dr. Jones to talk a little bit more about how we look at non-medical drivers of health.
Thank you, Dr. Cancino. So I wanted to first start with just providing a really brief, definition or explanation of what non-medical drivers of health are. And I'm sure many of you on the call are familiar, but we really think of it as these non-medical factors that are influencing our patients and our community's health outcomes. They're usually conditions, right, in which people work, grow, live, age, and play. And it's really this idea of the wider set. It's a wider set or net of forces and systems that shape the conditions of our daily lives. And so when we think about non-medical drivers of health and how they can help to promote colorectal cancer screening in men, it's really important that we first think about how we can build a collaborative team to support our male patients. So like Dr. Cancino was mentioning earlier, and when we think about this safety net or this collaborative team, it usually includes, social workers, financial counselors, community health workers, patient and community navigators, and volunteers. But each of these players bring a unique perspective and are able to help address different non-medical drivers of health. And when we think about this from a community perspective, we can really see it as it's a way, or when we engage the community, it's a way for us to define what specific non-medical drivers of health needs are. It allows us to align our efforts with existing resources, and it also helps to connect community leaders and organizations. And all of that combined can help create a comprehensive plan for a patient or a community member that we're supporting. When we think about minimizing barriers to the collection of this information, so we all know that in order for us to really know what a patient or a community member needs, we need to have a way of collecting this information. But it's important for us to think about some of those barriers at the patient level, but also at the healthcare system level. So when we think about collecting this information from the patient, we know that we are contending with, a patient's perceptions around transparency and trust, and their willingness to actually give us honest answers when we ask questions. We also know that there's barriers to the way that we collect the information. And we know that even if we're able to collect this information and have conversations with patients, there might be barriers and resistance to that patient taking action or allowing our teams, our CHWs, or our navigators to help with addressing some of those barriers. And so when we really think about it, addressing a patient's concerns and their potential barriers um, can be difficult, but if we can get over that, it's a way for us to help foster trust and collaboration to address these non-medical drivers of health. If we think about the barriers at a healthcare systems level, we know that there's other factors, right? And so one of those might be, well, how are we, securing or how are we ensuring that there's privacy and security when we collect this information? We know that there might be logistical challenges to collecting this information, right? So who might be the most appropriate person in a clinical care team to collect that information? What are those legal and ethical considerations, right? And what we mean by that is it's easy to ask a question, but if we receive a response, we need to make sure that there's someone in the clinical team or the care team who can help address that barrier, right? So it's more than just asking the question, but it's making sure that we can have a response or a solution to helping that patient with that identified need. And so, from the healthcare perspective, it's important for us to think about those proactive actions on the barriers. And so, one of the other things for us to consider is how we're able to increase a patient's comfort, right? And so when you're talking to a patient about, or when you're asking these questions, it's important to kind of explain the why. So why are we collecting this information? And how is this information, important or used to improving that individual's health? It's also important for us to think about the how. So how is the data being, how will the data help tailor services, programs, and interventions to better meet that patient's need? And the who. So who will have access to the information? So again, when we think about these things, it's really being able to explain to that patient and let the patient know that this information is being collected so that we can better assist them. This information is needed so that we can help connect them to the right resources. And we also want to make sure that they know who will have access to this information. And from a clinical care perspective, it lives within their chart and it's really only accessed by the provider and those who need to know. And so when we think about how, so you might be asking, and Dr. Cantino talked about this a little bit, but how do these non-medical drivers of health, impact cancer outcomes that we see in our patients or our communities? And so we're going to focus on three particular ones here, but what we do know is that people who are facing these non-medical drivers of health, they often experience barriers to healthcare access, which is, hindering their cancer outcomes. And there's three drivers, right? So it's the financial limitations, transportation difficulties, and work and family constraints. And there's a reason why we will be talking about these three, and I'll talk about them in a couple of slides, but we know that these particular barriers can actually contribute to delayed screening and diagnosis, and ultimately, reducing the success of a treatment if cancer is found. And we know that so these barriers can decrease adherence due to, or these non-medical drivers of health also decrease adherence due to logistical challenges, ultimately leading to poorer health outcomes. And so when we think about the impact of healthcare access and quality on men's colorectal cancer screening practices, we know that men usually having a usual source of care and regular healthcare visits are facilitators for colorectal cancer screening. The provider and patient relationship and the provider recommendations for screening are also tied to increased adherence. But when we think about our male patients in particular, we know that men are less likely to report having a usual source of care. Their Men have reported difficulty making colonoscopy appointments, and there's other constraining factors that are attributing to these screening adherence. And then there's the issue of financial and time constraints. And so when it's all said and done, when we think about some of these, it's really this idea of, so what can we as community health workers do, or how can we support our patients? Well, there's a few things that we can do, right? So we can discuss alternatives to colorectal cancer screening, which Dr. Cancino mentioned. There's different options, there's different modalities. We can help with scheduling. We can make sure that if we know a patient's coming into the visit to the clinic and they're due for their colorectal cancer screening, we can capitalize on that and have these conversations. We can have dedicated members of a care team kind of outreach to that patient to provide them with reminders or provide them with information on the importance of screening. And ultimately, we can help increase their screening for these male patients who are saying that they have issues with time. And so um, I'll save some of this for later, but another thing for us to consider is, what is when we think about the impact of economic stability on men's colorectal cancer screening practices. And so I won't go through the bullets, but I do want to focus on the orange piece here, right? So what we do know is that in order for us to improve our colorectal cancer screening adherence, it's important for us to ask our male patients about their economic stability, their home ownership, and these things might actually help us identify patients who might benefit from different colorectal cancer screening options. And what I mean by that is what the literature does tell us is that for men in particular, there is apprehension around getting their colorectal cancer screening because they may be primary source of income from their household, and they can't necessarily take time off of work, or they may not have, the benefits of paid time off or, sick leave that would help, offset some of that. And so for them, it's making a decision between, do I take time off of work to get this screening, or do I make sure that I'm able to provide for my family? And so by just being able to have these conversations around screening options or helping to, schedule around their availability, these are all things that we can do to help our male patients get their screening. In addition to that, we know that there's other, things such as the built environment. Again, I won't go through the top four bullets, but I think what we wanted to mention here is just the idea that we know that for some men who live in these areas of persistent poverty or in deprived neighborhoods, they're less likely to get their colorectal cancer screenings. And when we look at the literature to understand why that might be, what we hear is, well, one, from a preventive perspective, they may not live in an environment that supports healthy lifestyles, right? So they may not have access to safe places to be physically active. They may live in food deserts where they don't have access to foods, like fruits and vegetables that we know reduce risk for colon cancer. And they may just, have other behaviors that actually increase their risk for colorectal cancer. So if we're able to talk with our male patients about risk reducing behaviors, we might also be able to help reduce their risk, right? Doesn't mean that they don't need to get screened, but it's important to also talk about ways that they can reduce the risk for colorectal cancer screening. And I think another thing for us to think about is, as Dr. Cancino mentioned, there's this idea of their health belief, right? And how they perceive the risk to be. And so for men, we know that, social support, health literacy, and cultural norms are all going to influence whether or not they get their colorectal cancer screening. We also know that their knowledge of colorectal cancer screening is going to influence their intentions. And having poor health literacy may contribute to them just not really understanding what a colonoscopy is or what a colon is. And so just having that general knowledge and awareness is important. And then as Dr. Cancino mentioned, there's also this idea of the language barriers. We know that it's even more difficult for non-English speaking patients to have these conversations. And so these are all things that we contend with when we speak with our male patients. Not that it's exclusive to male patients, but we know that these are four literature stated things that we have to address with male patients. And then from the cultural perspective, we know that, if we think of our African American and Latino populations, there are other, things for us to consider, such as the real strong link to masculinity and gender, which might really discourage some of our male patients from wanting to get their colonoscopies or colorectal cancer screening because they see this as a violation of their masculinity. And so these are things that we as community health workers or individuals that interact with, patients and community members have to try to dispel, right? And letting them know that this is about being preventive and reducing the risk for colorectal cancer. And so the last thing that I wanted to talk about in terms of factors that influence male patients, decisions to get their screening is also the impact of medical discrimination. And so what we mean by this is, just this idea that patients, so some of our there was a study that was done that showed that, for our African American and Latino patients, they were actually more likely to see, to feel that they were treated unfairly in the past 30 days when they were receiving care. And so it's just one thing for us to consider. I think, when we think about programs for improving colorectal cancer screening rates, there's things that we do to interact with our patients, but there's also things that we do at the clinic level to help, kind of make these things better. And so in order for us to improve care teams' awareness of implicit, such as, right, improving our care teams' awareness of implicit bias and providing trainings to help them improve provider and patient interactions. And so just to kind of tie it all together, you know, we here at UT Health San Antonio Primary Care and the Mace Cancer Center actually have a study that we're doing that's actually looking at these different factors that are influencing our male patients' colorectal cancer screening rates. And so we are looking at three specific measures. We're looking at financial resource strain, housing stability, and transportation, and how this is impacting our own patient population's adherence to their colorectal cancer screenings. And so I'm going to hand it over to Dr. Cancino to talk a little bit about this project.
Right. So the project is called Checkmate, and we're really excited to talk about kind of early findings of this project with this group. I think this is probably one of the first public forums where we've talked about some of the results, and so you guys are getting a bit of a sneak peek of the work that Dr. Jones and I have been doing. So the Checkmate program is designed to improve colorectal cancer screening among men living in areas of persistent poverty by combining evidence-based screening strategies with community health worker-led patient navigation. The goal here is not only to address the clinical barriers that could be keeping our male patients from completing their colorectal cancer screening, but also identify the non-medical drivers which could be contributing to this, and honestly linking the team together, the primary care clinician, the office staff, the community health worker, to help support our patient population. This work is funded as a sub-award from the American Cancer Society for the Latino Cancer Health Center here at UT Health under Dr. Amelie Ramirez, and ACS has been a great partner in our work. So next slide. So to start, I don't think we said this at the beginning, but Dr. Jones and I have been working together now for, I think, almost more than 6 or 7 years. And so it's been such a joy to work with Dr. Jones really on anything, but particularly this. I think it sort of links her passion around community health workers and their training, and my passion around clinical operations and primary care and cancer screening. But it's a multidisciplinary group of people working on this. We have Saida Zuniga is our project area research area specialist, and then so far 2 community health workers who I'd like to give their flowers, Sonia and Crystal, who have been just doing an amazing job helping support our patient population and our community. And the primary care center is really one of the main locations where this study is taking place. UT Health San Antonio has 8 brick and mortar traditional primary care locations. It takes care of upwards of about 60,000 patients here in this community. And this is kind of the main place where this study is happening. But it wouldn't happen without the engagement of folks in those individual practices. So Dr. Jones, myself, and another physician named Dr. Cynthia Cantu have selected people we have called cancer screening champions at each of those individual practices who both motivate towards cancer screening, but also drive initiatives at the clinic level. And this is one of those initiatives that our cancer screening champions talk about almost on a weekly basis at team huddles at those clinics. So we have great engagement, not just sort of centrally on the research team, but clinically, where a lot of the recruitment is taking place. Next slide. And so what exactly are we studying? Well, first, we're looking at male patients that live in areas of persistent poverty that are seen in these locations. And then we're using the USPSTF guidelines to identify the high-risk patients in those groups. And right now we are screening males ages 45 to 75 who are either due for or overdue for colorectal cancer screening. And of those men, we are targeting men that live in census tracts identified as being in persistent poverty, right? Now, everyone will get, in general, standard of care. But in our intervention group, those patients will be screened for non-medical drivers of health by a community health worker. And then those community health workers, using the information from those screenings in partnership with the clinical practice that these patients are calling their medical home, will help navigate those patients to their colorectal cancer screening modality. Right now, some patients will need colonoscopies. There are groups of patients who cannot do one of the stool tests for whatever reason. And our primary care physicians are providing that information to our community health workers. And for those patients that would prefer a stool test, we're also making sure that it's an appropriate patient for one of those stool tests and providing a mechanism for those patients to provide that sample that is very patient-centered. And so our community health workers are acting like, patient navigators, schedulers, communicators here, and are really that link between patients, the primary care setting, and then any community-based resources these patients may have in the context of their screening of their non-medical drivers of health. Okay. All right. Next slide, please. I think we've already touched on what the risk factors that contribute to males not getting colorectal cancer screening. If patients live in areas of persistent poverty, that in and of itself, independent of being male or female or any other factors, is a risk factor, right, for having lower colorectal cancer screening rates. Folks who live in areas of persistent poverty have greater exposure to cancer-causing environmental exposures, lack adequate housing, experience higher risk of experiencing food insecurity, and have increased overall stress. And many have poor access to transportation and healthcare, either because of their context or just because the distance, right? Some of these areas are from high quality healthcare. And Dr. Jones already touched on the many non-medical drivers of health which can impact adherence to colorectal cancer screening. So I won't touch on those again. Next slide. Thank you. And so when we look at where our primary care locations are and where patients that are seen in those primary care locations live, we find high number of patients do come from areas of persistent poverty. And those are the patients, and these are the zip codes that we are targeting with our intervention. 78% of male patients who live in areas of persistent poverty also live in zip codes which are above the county rate for households with no vehicle. 59% of our male patients who live in these zip codes also are sort of highly vulnerable in terms of systemic social risk. And 13% of these patients live in zip codes above the county rate for household where rent is more than 35% of the household income. So these structural barriers, again, these non-medical drivers of health, which impact as much as 80% of a patient's health outcomes, this is the place where this study is happening. Next slide. And so we've been very systematic of how we think through this research project. And so we're using what's called conceptual models to help us think through how to structure our intervention. And basically, a conceptual model is kind of what we think is going on, right? What we think is going on in this patient population. We're using the health implementation framework and the consolidated framework for implementation research as the conceptual models upon which we are building our intervention. So I'll sort of guide you through this a little bit, but I'll try to keep it highly simple. So first, I want you to take a look like right in the middle with those three overlapping circles. Circle 1 is the intervention characteristics. Circle 3 is the care team factors. And circle 4 is the patient factors, right? Where these circles overlap, that is kind of what happens in the clinic, right? When you go to see your PCP, right? That's the clinical interaction. That clinical interaction does not happen in a bubble. It happens in the context of the healthcare system, right? It happens in the context of the city or the county. It also happens in the context of the societal influences that are impacting the people that are in that conversation, okay? Where this study takes place is number 4, patient factors, right? There are some components of those patient factors that impact whether or not a patient will go to the appointment in the first place, will make the decision to get the colonoscopy or do the stool test. And that's really where this study lives, where we're looking at socio-demographic information, behavioral risk factors, those non-medical drivers of health, which a patient brings with them to every interaction they have during the day, not just their interaction with their physician or the healthcare system, okay? And then from an implementation science standpoint, if you take a look at the far right, we're really looking at step by step, what are we doing and is it making a difference? Everything from the screening to the electronic health record we're using to whether or not at the end of the day, the goal is for the patients that we interact with to get their colon cancer screening. Okay, that's success for us at the end of the day. I'll turn it onto the next screen, and I think Dr. Jones, you'll talk about our inclusion criteria.
Yes, thank you. And so, in terms of the study itself, and so, a lot of what we're doing is really looking at this interaction between the community health worker as a member of the care team and the patient, and really looking to reduce those barriers. And so from a study perspective, we talked about who's included in the study. So males who are due for their screening and live in these areas of persistent poverty. And as Dr. Cancino mentioned, they'll either receive their usual care or they'll receive the Checkmate study. But all in all, we're looking to include around 252 patients in the project. And our community health workers are only, providing this really close one-on-one navigation for patients that are enrolled into Checkmates, and they're reaching out to them as needed to make sure that we're addressing their barriers. And so what I wanted to focus on was just some of the preliminary findings. So we've been in the process of enrolling patients into the study for about a year now. We've been able to successfully enroll 43 patients to date. And so just a little bit about the characteristics of our patient population, right? So if you remember, Dr. Cancino showed the map of Bexar County with where our patients reside in these areas of persistent poverty. So from a race ethnicity perspective, over half, so about 63% of the patients, the male patients in our study are Hispanic, 33% are non-Hispanic white, and about 5% are non-Hispanic Black, right? Very much aligned with the population in Bexar County. From an age perspective, one of the things that we were interested in is actually looking at or making sure that we recruited patients and that we looked at it from this under 50 versus over 50. And part of that is because we know, like as we were writing this project for ACS to review, the guidelines changed. And so now the age for screening is 45. And so we thought it would be kind of neat to look at our patient population from this under over 50. 50 was originally the age for screening. So to date, around almost 80%, right? 74% of the patients in Checkmate so far are over the age of 50, but we do have about 26% who are under the age of 50. So it's going to be really interesting to see the characteristics and the screening rates for these under 50 so we can start to tweak the way that we talk about risk with this lower age group. But in terms of how we're doing, right? So again, we've been able to recruit, of the 43 patients that are enrolled into the project, 21 of them are actually receiving Checkmate, right? The other 22 are getting standard of care. But what we see is that 57% of the patients who are engaging with their community health workers have actually received their screening to date. That's compared to 18% of the patients who are receiving standard of care. And I know the percentages might be like, well, what does that really mean? So as I mentioned, we have around 43 patients enrolled in the study. 12 of them, 12 of the patients in the intervention group 12 of the 21 have received their screening, and only 4 of the 22 in the control group have received their screening. But something else that we wanted to kind of look at, right? So we mentioned we know that for our male patients, time is a barrier. Loss of income, potential loss of income is a barrier. Transportation is a barrier. And so we are offering our patients all of the different screening modalities that they're eligible for. So what you kind of see here is just like, well, what test are our male patients choosing? So for the intervention group, we've had 9 of the patients, of the 12 patients in the intervention group who have received their screening, 9 of them opted for the colonoscopy, which, depending on the results, might mean that they don't need to get another screening for 10 years. And 3 of the patients in Checkmate, right, have actually opted for the Cologuard, meaning that they will need to get rescreened at 3 years. In the control group of the, 4 patients who have actually received their screening as part of usual care, they've all opted for a colonoscopy. And so, as Dr. Cancino mentioned, one of the purposes of our project is to actually understand, like, how is all of this working? What's working well at the clinic level, what's working well at the patient level, and what might some of those barriers be? So understanding, like, our male patients' decision making in terms of what screening they're ultimately going with is something that we'll be studying as we get later into the project. And so just some really brief, so this is definitely some of the preliminary findings, but as we know, we're looking to really cut down on these barriers that our male patients are telling us. And so what we've seen so far is about 5% of the patients who are engaging with their CHWs have scored high risk for financial resource strain. 10% have scored high risk for housing instability. And with the patients we've spoken with, they've actually not necessarily disclosed that they have transportation needs. And from a health literacy perspective, just some of the things that I'll mention, maybe I'll just touch on the last one, but what we see from a health literacy perspective for the male patients who are interacting with our CHWs is that 29% of them have indicated that their family and friends either sometimes or always have to help them read the information or the instructions that they're receiving from their medical care team. And so these are, again, just really preliminary. We're early on in our recruitment efforts, but it is interesting to see what this looks like for patients in Bexar County. And so I'll kind of hand it over to Dr. Cancino if he has any thoughts too on some of the preliminary findings before we open it up for questions.
No, I think part of what I think is important to communicate to this group is that, everyone is trying very hard in healthcare right now. No one wants a patient not to get a colonoscopy. No, no one wants a patient to get cancer. And so everyone's working very hard. And I think we have to recognize that what we are trying to study is, might there be a better way? And might there be resource in community health workers, which could serve the needs of both patients as well as communities. And that is, a really important, I think, question we're trying to ask above the goals of this specific project. And so, again, thank you very much, everyone, for inviting us here today, and happy to take any questions.
Hi,
Thank
Dr.
you.
Oh, sorry.
Sorry, Paula. Thank you,
Yes.
Dr. Cancino and Dr. Jones. I will open it up for questions and I'll turn it to Paula.
Yeah. Sorry, guys. Hi,
Yeah.
this is Paula Winkler with South Central AHEC. Um, so lately we've been here. We had this is the presentation today. Thank you much. Was very timely because this morning we had quite a large discussion about colorectal screening and opportunities for different programs. Um, so this came in very, very handy for community health workers. Is there any opportunity to take a look at ways that we could get out into the community, especially in those community zip code areas that you're looking at within Bexar County, to talk about, well, first of all, do they need to be patients of these clinics, or can they try to come into the clinic? I'm not real sure how that happens. If you could kind of give me some clarity on that.
I think Dr. Jones can maybe talk about that, and then I can supplement. Go ahead, Becky.
Sure. So, for the purposes of our Checkmate study, so it is currently just for patients who are active patients within our UT Health Primary Care. From an education perspective, our Mays Cancer Center Community Outreach and Engagement does actually do outreach and education on colorectal cancer screening risk and screening options as part of our, just general community education. And we can get with you, Paula, and others about some of those opportunities.
Thank you. Thank you.
And that often opens up another question, and I guess it is so important for a patient needing colorectal cancer screening to have that medical home.
Mhm.
And the reason is because, number one, we've seen it, right? Somebody gets a colonoscopy or a FIT test and it comes back abnormal. Not only does the patient have a lot of questions and concerns and in need of resources, but in some ways, there are situations where even patients don't even understand the results and carry on as if nothing was abnormal. And so I do think it's important. The screening activity, I think, is important, but there needs to be somewhere where that kind of lives. And, I'm a primary care physician, so I guess my bias is that it's important for folks to have primary care physicians, but I think being connected to a medical home is probably just as important.
I have another question, if I could, please. Thank you, Dr. Cancino. I agree with you totally. But what we've been hearing is that much younger men are now being diagnosed with a very serious stage 3 and even stage 4, and they've not even reached the 45 age limit. So my concern is obviously is that for younger men who don't necessarily have a primary care because they feel like that they're invincible. So how do this is where the CHW can come in very, very, very helpful. The community CHWs who can connect them with the primary care clinic CHW to kind of go forward. Is that some way that we might be able to move that through? What is your thought on that?
I think that's a broader question about healthcare access to
Mm-hmm.
primary care, which we can talk about offline. I think when you look to the research about why younger men, even younger than 45 these
Right.
days,
Right.
are getting diagnosed with cancer, I think the jury's still out, but much of the reasons for that outside of it being multifactorial, are pointing towards the gut biome and
Mm-hmm.
exposures that that gut biome is experiencing either in the environment or otherwise. And so, again, I think it's two different questions. It's about, well, three different questions. It's about when is an appropriate age to start screening patients for colorectal cancer screening.
Mm-hmm.
And, right now we're at 45, but that might change over time. Second, it's primary care access for patient populations. That's a big challenge,
Mm-hmm.
especially in Texas, especially in some of our rural communities. And then third, it's navigation and what are community health workers' role in terms of that. I think, those are important questions to discuss. We probably won't find the answers today.
Right. Thank you.
Thank you. So we have time for maybe one more question because we're right at the top of the hour. I know there was one question in the chat that said for individuals with a family history, how do you adjust the standard screening guidelines?
It's a great question. In general, you need to know in general at what age that family member was diagnosed, whether or not that family member is first degree relative or second degree relative or third degree relative. And in general, it's 10, you start your own personal screening 10 years, 10 years before the age that your family member was diagnosed, right? Now, there are also genetic risk factors for colon cancer. And so if you have a known familial or genetic reason that you might have colon cancer, that screening actually might start even sooner. So I think it would be very important to get your family history. Men often don't know their own family history, especially as it relates to colon cancer. And then discuss that with your primary care physician, and then they can let you know what screening age you should start at, and actually what screening modality would be important for you to do. Because many people with a strong family history of colon cancer probably shouldn't do the stool test. They should do the colonoscopy because that's the gold standard. Good question.
Thank you, Dr. Cancino. Marta, one last question real quick.
I wanted to ask if, because we're going to start a men's group where we have a women's group, and I wanted to ask two questions. Does it have to be, well, I think that we have four promotores that we want them to work with the men. And have you experienced whether it makes a difference, whether it's a male CHW or a female CHW? And two, do you have community support, like a center where they all gather and be able to form their own support group?
Dr. Jones, I'll let you take that one.
Sure. So, starting with the last question, so we don't necessarily have a support group specifically for male patients or anything like that. But I mean, I think if that's something that you want to explore, like we can have a conversation around how our community outreach and engagement group can get involved. In terms of differences between, the receptiveness of male patients to a male versus female community health worker. So our team is we have, it's two female CHWs that are working on our Checkmate study. When we ask them, like, do they hear any hesitation or apprehension from the male patients having these conversations with them, they've indicated they haven't, but that's something that we will explore qualitatively through interviews towards the end of the project. What we do know, Dr. Cancino and I, from the colorectal cancer screening, this is one project, but we've been doing over about 7 years worth now of CHW supporting our male and female patients with various different cancer screenings. And we haven't really experienced, the difference from like a male or female. I'm not saying that there isn't. I'm sure there's literature that says that their males might be more responsive to males, but one thing that we do know is that most of the time the patients we speak with just are appreciative of the fact that there's somebody who's
Mhm.
actually reaching out to them and caring enough, right, to have these conversations with them. So
Thank you very much.
Thank you guys. What a great presentation. I think we all have had firsthand experience with people that have been diagnosed with colorectal cancer. So very, very important topic. We really appreciate it.